الدكتور جمال ستيتية. الدكتور جمال ستيتية تخرج من الجامعة الأردنية كلية الطب سنة 1982. حصل على البورد الأمريكي في الأمراض الباطنية سنة 1993 والبورد الأمريكي في أمراض المفاصل والروماتيزم عام 96. حاليا هو في الممارس في القطاع الخاص، وكذلك هو بارت تايم كونسلتنت في مركز الملك حسين لأمراض السرطان. الدكتور جمال ستيتية his main interest في الروماتويد ارثرايتس واللوبس والباسكولاتس والاكسترا ارتيكولار مانيفستيشن للكونكتيف تيشو ديزيزز. دكتور جمال تفضل.
شكرا دكتور بديع الصالح على الانترودكشن. بسم الله الرحمن الرحيم. الموضوع اللي حاحكي فيه أنا هو موضوع يعني بهم الروماتولوجيست، وجوز يعني هو قليل بيتحدثوا فيه، ألا وهو reproductive immune mediated failure in patients who have repeated implantation failure in patients who have assisted reproductive technology. Okay, the first case is a 34-year-old female who was married for 15 years, and she had 17 trials of failure of IVF. She tried aspirin, enoxaparin, and prednisolone milligram daily in 7 trials out of the 17. Her ANA was borderline, and her CD56, which are the natural killer cells, was double upper limit of normal. The second case is a 30-year-old female who was married for 7 years. She had 1 daughter with normal spontaneous pregnancy, and she failed IVF trials. Number was 2. She received aspirin, but the important thing that her past medical history, she had immune thrombocytopenia in 2006, treated by hematologist, and she had also hypothyroidism, and she was on isoxazoline. The case number 2 had ANA of 1/160, and ENA showed Rho 52 +2 and histones +1. Of course, I will talk about the result of these cases at the end of my talk. The case number 3 was a 21-year-old female. She was married for 3 years, and she failed 2 trials of IVF, and her mother had lupus. Yet herself, she did not have lupus, but she had ANA with the titer, which was high, and she had no clinical lupus. Now, when we talk about autoimmunity in general, we talk about antinuclear antibody, which is the prototype of autoantibodies in a human being. And it was studied in patients who had attended attended first visits to the clinics with infertility, and it was found that patients who were positive for ANA had half the rate of implantation success and half the rate of pregnancy rate compared with patients who were negative for ANA. Another meta-analysis done on patients who have ANA and repeated pregnancy loss. Patients did not have autoimmune diseases, just positive ANA versus controls. It was checked in patients who have RPL, and it was found that in 22% of patients have ANA, while in the controls who did not have repeated implantation failure had a percentage of 8.3%. Now, what about thyroid autoimmunity? It was found that antibodies to the thyroid peroxidase and antibodies to thyroglobulin were studied in pooled results like a meta-analysis. Those women were attending infertility clinics, and the relative risk of patients who have antibodies was 2.1 compared with patients who have negative thyroid antibodies. And it was found that thyroid autoimmunity was associated with high peripheral natural killer cells. They have altered immune status, and it might have also possible negative impact on pregnancy outcome. And thyroid autoimmunity is considered as a possible independent or marker of repeated implantation failure, mainly infertility and miscarriages. Thyroxine hormone administration in those patients reduces the risk of obstetrical complications in general, mainly regarding implantation failure. Now, what about antiphospholipid antibodies? Do they cause infertility? We know that they cause recurrent abortions, but do they prevent pregnancy or prevent recurrent implantation failure? The answer is the retrospective study here that it was studied in patients who have hypercoagulability, whether it is due to antiphospholipid syndrome or hereditary. It was not associated with the failure to achieve pregnancy. Another study, which is a review of 29 studies, there was found that there was no association of antiphospholipid antibodies to infertility or IVF outcome. Now, from antibodies, we go to cellular immunity. And the prototype of those is natural killer cells. We have other cells, which I will talk about in a minute. It was found that natural killer cells in 3 groups, they were studied in biochemical pregnancy, which is just chemical pregnancy, high HCG. It was studied also in patients who have miscarriages and in patients who have successful live births. It was found that the NK cells were significantly higher in patients with the above 2 groups compared with patients who have successful live births. T cells, T helper 1, T helper 2, T helper 17, and regulatory T cells. Repeated implantation failure was checked in patients who have those cells were checked in peripheral blood in patients with repeated implantation failure. They was found to have high peripheral Th1 to Th2 ratio. They were found to have high Th17, and they were found to have low T regulatory cells. So this means that higher Th1 to Th2 cells might be a factor which contributes to repeated implantation failure. So now we have this background. What tests we can do to check for autoimmunity? We check for antibodies to antithyroid globulin, antithyroid peroxidase, and we check for TSH. Why TSH? Because it has some implications in increasing the success if given to patients with such kind of autoimmunity with thyroid antibodies. We do ANA by immunofluorescence, and we check the NK cells by CD1656 markers, Th1 and Th17 by flow cytometry. Now, what about treatment of repeated implantation failure? We have different modalities. Some of them are being used, some of them are at research level, and they are glucocorticoids, intravenous gamma globulins, and intravenous intralipids, adalimumab. We have hydroxychloroquine, calcineurin inhibitors, thyroid hormones, anticoagulants. Okay, 16 randomized clinics in around 2,000 couples. The autoimmune status of those were not determined, okay? And it was found that glucocorticoids given before embryo transfer did not increase the incidence of successful pregnancy. Okay, what about intravenous immunoglobulins? A meta-analysis of 10 studies. They were case-controlled studies in patients who have unexplained infertility, and in patients who have IVF fertilization, and in patients who have intracytoplasmic semen injection. The autoimmune inclusion criteria were unnecessary in such kind of treatment, and they were given IVIG versus placebo. It showed that giving patients IVIG increases the implantation rate by 2.7 odds. It increased the clinical pregnancy rate by 1.5-fold and the live birth rate by 1.6-fold, and it decreases the rate of miscarriages to 0.35. These did not have statistical significance, but they can point that IVIG can be useful treatment in patients who have repeated IVF failure. Now, a systematic review from the UK about IVIG also. They studied IVIG with prednisolone in women who were going assisted reproductive technology. And those patients had, in particular, abnormal NK cells, numbers, or activity. 2 studies showed that it increases the rate of success by 3.4 folds and the live birth by around 4 folds. The conclusion of this study was that it is beneficial. A meta-analysis in another study about 4 placebo-controlled trials. Patients had immunological abnormalities with their NK cells or autoantibodies. The pregnancy rate in the cohort group was increased by around 1.8-fold, and in the cross-sectional studies, around 11.1-fold. That was the pregnancy rate. What about the live births, which is the end product of what we want? In the cohort study, around 2.17 increase in the success rate, and in the cross-sectional studies, the live births were around 7.57. So IVIG may be beneficial in repeated implantation failure patients selected according to relevant immunological disturbances. And the dose, if we want to give it to the patient, is 200 to 500 milligram per kg body weight. Personally, I use the lowest dose. We had some cases of success. We have some cases of failure also with IVIG. But it increases the rate of success. It is given 1 to 7 days before embryo transfer and given every 3 to 4 weeks during pregnancy till we reach at least 8 months of pregnancy. What about intravenous intralipids, which many people talk about in such conditions, and I've seen patients who've taken IV intralipids by other colleagues. We know that IV fat emulsions given for parenteral nutrition can decrease the effectiveness of pro-inflammatory cytokines, and that was the rationale behind using this in such conditions. Now, if it is used in such conditions, it was found that clinical pregnancy as well as live births in patients who have IV intralipids versus placebo is almost the same in this controlled trial. What about adalimumab? Relatively safe in pregnancy if we weigh benefits versus risks, but still anecdotal evidence suggests that it is useful. In a prospective study done between 2017 and 2022 on 395 patients, 67 of those patients had autoantibodies. And those 395 patients had around 2,700 pregnancies. And among those patients, the ones who were having treatment, they were 494 pregnancies, not patients, 494 pregnancies. We're using steroids, azathioprine, hydroxychloroquine, etc. But what about adalimumab in such conditions? 69 cases of pregnancies were on adalimumab. The cumulative live birth rate versus untreated patients who did not take adalimumab or other immunosuppressive agents, the odds ratio was 3.5 with confidence intervals which was significant. Now, what about hydroxychloroquine? It is very safe in pregnancy, and it was found that repeated implantation failure and high TNF-alpha IL-10 ratio during implantation, it decreases this ratio by lab studies. So what about its use in practice? This is a study 4 years ago using prednisolone and hydroxychloroquine in patients who were ANA positive. The biochemical rate with the treatment group was 68% compared with 33%, and it's almost double with the clinical pregnancy. The implantation rate was almost 5 times the patients who are on placebo arm, and the pregnancy loss was almost 1/4 of the placebo arm. So hydroxychloroquine, personally, I use it with any patient who has autoimmune phenomenon, autoimmune antibodies, thyroid antibodies. What about althioxin? The European Thyroid Association guidelines recommend the use of thyroxin in patients who are pregnant with overt hypothyroidism if the TSH is more than 4 value, and if the TSH is below 4, and still above 2.5, we need to use it in patients who are pregnant with autoimmune thyroid antibodies. Tacrolimus and cyclosporin, still not much studies, just reports with potential benefit of such kind of treatment. I personally did not use it so far. Aspirin and heparin have no use with different studies. They might be helpful in patients with antiphospholipid syndrome miscarriages, but not in patients who have repeated implantation failure. So the case number 1, which had high level of NK cells, the next step was IVIG for 7 doses, and eventually she had normal delivery. The case number 2, which had ITP and hypothyroidism, I checked her thyroid antibodies and they were all positive with high titers. I gave her prednisolone and also hydroxychloroquine, okay? And she had normal delivery eventually. Case number 3, the one with a mother who had lupus and high titer ANA, the next step was giving her hydroxychloroquine, and she had spontaneous pregnancy even with the preparation before she got the pregnancy, give her hydroxychloroquine before implantation or before pregnancy. She delivered at 38 weeks. So the take-home message is that there is a good evidence that immune-mediated mechanisms play a role in repeated implantation failure. The role of hydroxychloroquine, adalimumab, and IVIG in treatment of immune-mediated IVF, RIF shows promising results. There were no controlled studies showing benefit of prednisolone, heparin, or aspirin in immune-mediated repeated implantation failure. Antiphospholipid antibodies' role in IVF outcome still needs to be determined. We know its role in antiphospholipid syndrome, but not with IVF failure. And the best thing we can offer to our colleagues, the gynecologists, by the willing of Allah, is the gift of life. Okay. Thank you.
Thank you, Dr. Jamal.